Hello and welcome back for the part two of this lecture dedicated to the basics of neurogenetic and neurometabolic disorders from a radiological point of view, of course. And I want to start this second part that will be dedicated to mitochondrial and neonatal disorders with these amazing albums by the Muse called The Origin of Symmetry. And why it's so important? Because when you see something symmetrical, bilateral and symmetrical in the brain, you need to think neurogenetic, neurometabolic, although other etiopathogenetic factors may be involved, like for instance, toxicity or drug-related neurological damage. But as a general rule, when you see symmetry, consider, please, abnormality in the realm of neurogenetic, neurometabolic disorders. And also in this second part, as I did before, I want to suggest some readings for you guys, because I will do some, I will show some simple pattern recognition, but actually you can go deep and deep in the science of especially mitochondrial disorders, and there are levels to this game that you will like to explore. And to do so, I would suggest you to look at the papers from my dear friend Cesar Alves, who works in US, and he published basically everything about the mitochondrial disorders and radiological patterns associated with this. And really, you need to check these papers out. These are just four of the most intriguing papers, but there's a bunch of them. Starting with pattern, let me show you this. That is a case of basically a leukodystrophy, bilateral symmetrical abnormalities in the white matter, but not only. And the first part of this lecture was about leukodystrophy, so this is part of the leukodystrophy spectrum. But look at the appearances in this case. There is, first of all, in this ADC map on the left and the DWI sequence at the center, you can see this striking diffusion restriction, also involving the basal ganglia and the posterior aspect of the corpus callosum. The changes on T2 are extremely florid, extremely hyperintense, and of course, in this case, we also have the benefit of knowing that the child has an elevated lactate in the CSF. Another similar case is this one published by Caesar. Again, look, these very florid changes on the white matter. This is a flare that shows a central cavitation in the white matter with an association, this very characteristic rim of diffusion restriction, which is critical for your differential diagnosis, because when you see a cavitating leukodystrophy with this age of restriction that you can see in both the cases, with or without involvement of the basal ganglia, think mitochondrial leukodystrophies. And one of the paper related to this topic is this one in AJNR. This pattern of cavitating leukodystrophy was first described in the early 2000s by the group from Gaslini, and since then, more and more genes have been discovered being responsible for this pattern. So when you see something like that again and again, this is pattern recognition. Think mitochondrial leukodystrophy. And remember, the bilateral symmetrical involvement of the basal ganglia is typical of the mitochondrial disease, but we not always, actually quite rarely, have this associated leukodystrophy. So I thought I wanted to show you this pattern. Sometimes we have cavitating leukodystrophy like that, without this florid abnormalities that are very bright in T2, despite the cavitation is visible in this case in flare, and despite this, the possibility of mild restriction, there is not prominent age of diffusion restriction as I showed you before. And when you have in a situation like cavitating leukodystrophy, in a situation especially where the child has cerebellar ataxia, Even more so, if the clinical history is characterized by minor trauma, you need to think vanishing white matter. So when I saw the case before, that I showed you before, that was a mitochondrial leukodystrophy, I didn't know about this pattern recognition, and I called vanishing white matter because this was the only vanishing leukodystrophy that came into my mind. But actually, if you see several cases of these two big categories, despite the cavitation and vanishing of the white matter being present in both of them, there are substantial differences, not last of them, the clinical history in this case. And you can see the atrophic evolution over time. So remember, diffuse white matter signal with this flare hypo intensity, which means rarefaction. There is no basal ganglia involvement. The sparing of the corpus callosum, there is some mild restriction, but not this prominent age as I showed you before. And remember the clinical course, a child initially normal with, after minor trauma, progressive deterioration characterized by ataxia and spasticity, and then more acute episode associated with trauma and infection going on and progressive degeneration. This is the vanishing white matter, and we have the gene that is called EIF2B. So you see something like that. Again, you can suggest the gene, especially if you have the benefit of the clinical scenario. Of course, everybody knows that bilateral symmetrical abnormalities in the basal ganglia, most often sparing or involving less the globus pallidus, but there are exceptions to that, like for instance, Kearns-Sayre disease. But this kind of pattern is typical of mitochondrial cytopathy. So you see like that, you call it Lee syndrome and you think mitochondria. However, remember that very similar appearances are also typical of something that is not mitochondrial and can be cured. And especially if you see this characteristic cortical subcortical hyperintensity that are a bit less expected in mitochondrial, you need to think of this entity called biotin thiamine responsive basal ganglia disease. So this is treatable, and every pediatric neurologist dealing with neurometabolic disorders knows that if you have something that looks like Lee, you give a biotin and thiamine in the hope that this is not, in fact, a mitochondrial cytopathy, but this curable condition, biotin thiamine responsive basal ganglia disease. So generally, according to this paper by Kassem back in 2014, you should think biotin thiamine responsive disease every time you have bilateral symmetrical basal ganglia involvement, because the two conditions radiologically overlap massively. Although there are a lot of other conditions that overlap and involve bilaterally and symmetrically the basal ganglia. Of course, hypoxic ischemic injury in a neonate, these are very sensitive areas because of the high metabolism, so they can have bilateral and symmetrical involvement of the basal ganglia and thalami. Normally, you have posterior putamina and ventrolateral thalamus involved, with sometimes perirolanthic region also involved, and the typical perinatal history. But also post-inflammatory condition. Some people believe in this entity called PANDAS, post-streptococcal, ANEC associated with H1N1 or other infection can give you bilateral involvement of the basal ganglia. So remember that it's not all metabolic or mitochondrial or biotin thiamine responsive disease. Speaking of symmetry and mitochondria, there are other patterns that you need to keep in mind and are not completely consistent with the Lee original described phenotype. So we have two, in this case, 2-year male with vomiting, spasm, and seizure. And what we have is this characteristic symmetrical abnormality in the brainstem. You see here this hyperintensity in the midbrain, pons, and cerebellar peduncle and deep cerebellar nuclei. and this is a pattern, again, bilateral and symmetrical, but without involvement of the basal ganglia whatsoever. Keep in mind that this is, again, pattern recognition. There are some mitochondria that involves only the brainstem and cerebellum, and they spare the basal ganglia, like, for instance, COX deficiency with SIRF1 mutation is one of the many, but remember that the Lee syndrome is not only confined to the basal ganglia. And this is the paper, again, from Professor Rossi and colleagues back in 2003 that originally described this pattern. Another very important pattern, progressive spastic ataxic gait in a 20-month female that had also impaired fine motor skill. And you see in this case, we have lactate again, and then when we see lactate, we think mitochondria. Those we have involvement of the brainstem, in particularly trigeminal tract. We have involvement of the middle cerebellar peduncle. We have involvement here of the plique/thalami and leukodystrophy, and also involvement of the spine. When you see something like that, again, think mitochondrial. This is another mitochondrial leukodystrophy. And remember, it's very important to check for the spinal cord and brainstem involvement. There is another paper by Cesar Alves and colleagues about the spinal cord involvement in mitochondrial disease that is often neglected, and involvement of the corticospinal tract, pontine trigeminal tracts, very typical. No basal ganglia involvement. If you spell out this radiological description, what you have is leukoencephalopathy with brainstem and spinal cord involvement and increased lactate, LBSL, DARS2. There is a version of it with hypomyelination, so it's not so prominent. The appearance of a leukodystrophy is another ARS genes. These are RNA transferase genes, but this pattern is very typical. So in this case, you can suggest the gene, but also you can, suggest mitochondrial leukodystrophy, and your colleagues will take from there. Another typical pattern, another ARS gene with leukodystrophy. In this case, the thalami are completely involved. The posterior brainstem is also involved. There is lactate, and is leukoencephalopathy with thalamus and brainstem involvement and high lactate, LTBL, ERS2, so another genes, same group of genes involved. So thalami and brainstem, posterior midbrain, very, very typical. Remember, you can have some situation where the corpus callosum is involved. There are a lot of neurogenetic and neurometabolic disorder that may present with malformations, as well as explained in the paper by Astik Biswas that I suggested in the part 1 of this lecture. So ERS2 also can appear with the malformation of the corpus callosum. Another mitochondria that can have malformation of the corpus callosum is, for instance, PDH mutation. So remember the fact that neurogenetic disorder can present also with malformation in the brain, and I will show you some example later on. Before going to the following part of this lecture, which is neonatal, don't forget the uncommon. Sometimes asymmetric involvement, stroke-like involvement of the cortex, jumping around in an erratic way around the vascular territories of the brain with associated lactate is really suggestive of MELAS, which is a mitochondrial disorder characterized by stroke-like episodes. Another kind of similar group of disorders are POL-G-related disorder like Alpers syndrome, for instance, and again, the group from CHOP, in this case, the first author is Fabrizio Gonçalves, demonstrated that POL-G-related disorder may have these characteristic findings in association with epilepsy, bilateral or unilateral involvement of the peri-Rolandic region with diffusion restriction, thalamic involvement of occipital involvement, sometimes alteration of the perfusion. At least part of these changes seems to be due to seizure-related kind of effect on the brain. And if you really want to know everything about what we know on seizure-related changes in the brain, check out the other talk in my YouTube channel done by Professor Tortora from Gaslini. That said, these are two important patterns that are included in the realm of the mitochondrial disorders you need to know, because you don't want to diagnose this as HIE or stroke. This is very, very important. Now, the last part is that a neonate is not just a smaller child. There are some specific neurometabolic genetic disorders that present in the neonatal period. Again, I suggested in the part 1 some papers, the amazing paper by Poretti and Blazer about inborn metabolism disorder presenting in neonatal age is really a pivotal paper, so please check it out. But here I just want to show you some cases that are very typical. Again, the importance of pattern recognition will be stressed, but also quite rare. So if you forget them, you can either report this as normal or get confused by the clinical findings. And I want to show you this case typically presenting in neonate or infant. In this case was an infant 8 months old with hypotonia, seizure, and dysmorphic feature. So when you see dysmorphic feature, think neurogenetic again, and look very carefully at this brain. First of all, I told you that in the neonate, the plic, posterior limb of internal capsule, should be myelinated. Here it's almost impossible to see any myelination in this area. On top of that, if you look at the cortex, while quite smooth in the occipital region, is actually quite abnormally folded with these lumpy, bumpy appearances in both the Sylvian region. And this is a typical appearance of polymicrogyria. There are also cysts, subependymal cysts, that you can see in the coronal T2 as well as in the sagittal T1, and a bit of small points. This combination of finding bilateral asymmetric polymicrogyria, hypomyelination, and subependymal cysts are typical of Zellweger syndrome, which is a peroxisomal disorder, and we have the gene for that. So when you see this combination with this subependymal cyst, think Zellweger. There are other diseases, like for instance, PDH, again, can present with subependymal cyst, but otherwise, outside any striking clinical and radiological context, you can consider them incidental. But keep in mind that subependymal cysts sometimes are a clue for you to look at other subtle findings like hypomyelination, polymicrogyria in the context of Zellweger. Another neonate, 2 weeks old. Now, remember, if you have an HIE, you will have a damage or clinical symptoms rather immediately after birth. You will not have any symptom-free interval, and this is very important because even 2 weeks in a neonatal age are very, very important to guide you in the differential diagnosis. Because if you have a neurogenetic, neurometabolic disorders, and you are accumulating toxin that before were metabolized by the mother, you will need a few days, a few weeks for these toxics to accumulate and create symptoms. So 2 weeks in this case are in a normal born baby are critical to guide your differential diagnosis toward a neurogenetic neurometabolic disorder. And again, you cannot see the myelin at the level of the posterior limb of the internal capsules or plics. You cannot see myelin in the posterior fossa. These are both areas that are expected to be myelinated at birth. And if you do a diffusion, you will have a myelination map. The areas that are myelinating actively at this age are bright, probably because of intramyelinic edema, and this is typical of urea cycle disorder, in particular MSUD, map-posterior urine disease. This is the more typical. We have other disorder that can involve these same areas that are metabolically active, but in a bit less striking fashion, like urea cycle disorder. Other urea cycle disorder can have subcortical restriction, especially in the insular region. Aminoacidopathy can have this corticospinal tract involvement. But when you see something like that, please call it MSUD or map-posterior urine disease. Another example of involvement of the same areas, but less striking, you see a faint restriction in the posterior limb of internal capsule and here in the brainstem. Again, there is a malformation. It's not a polymicrogyria like in Zellweger, but there is a small corpus callosum. In this case, please do a spectroscopy, and do a spectroscopy with an intermediate or long echo time, because you will see increase of glycine peak. This is non-ketonic hyperglycemia. And again, this is the paper by Poretti and Blazer that is very typical, very critical for you, and show this very typical involvement of the corticospinal tract with this glycine peak at 3.55 long T, because otherwise you can have an overlap with myoinositols that can be a pitfall. So remember, corticospinal tract involvement, this MR spectroscopy pattern, and abnormal corpus callosum in a neonate screams non-ketonic hyperglycemia. The last case that I want to show you is another pattern recognition case. Is very, very important, because this is, again, the clinical context is important. This is an infant with deafness and some mild motor delay and prenatal diagnosis of hydrocephalus. So deafness and very minor neurological symptoms do not let you expect this terrible appearance of the brain. You have short dysmorphic corpus callosum, midline cyst, bilateral nodular heterotopia, and polymicrogyria. And also, together with this dilatation of the ventricles that we call colpocephaly, that is secondary to the small corpus callosum, we have this characteristic inferior cerebellar dysplasia. Inferior cerebellar dysplasia is somehow common and non-specific, but when you see in the context of deafness and this associated malformation of the brain, this is again pattern recognition. There is only one possible diagnosis, which is Chudley-McCulloch syndrome due to GPS-M2 mutation. Why is so important? Because the neurological outcome and the prognosis in this case is very good. And when we have these abnormalities that in a fetal scan, you may want to suggest this gene, because the prenatal counseling is different, and the parents may well decide to keep the baby, because this is not a baby that will have a dreadful neurological outcome. So this is where we as radiologists can make a difference if we know this specific pattern recognition. Again, guys, please check out the paper that I suggested you, because this is just touching the surface of what I found very helpful in my daily radiology life, or life of a radiologist in a big pediatric hospital. But there is more and more that can tickle your curiosity, and really you need a lot of time to call yourself an expert, and you need to keep studying every time you have a bit of time. This brings me to the conclusion. Remember, there are different and complex classification for neurogenetic and neurometabolic disorders, but you can use the pattern recognition radiologically together with the clinical aspect to guide your differential diagnosis. And this is important in specific cases where you can make the difference. I've shown you the Chudley-McCulloch, but also the biotin-thiamine responsive basal ganglia disease, for instance, or a treatable condition like some of the neonatal inborn metabolism disorders. Look for selective susceptibility, look for symmetry versus asymmetry, and be aware of the differential diagnosis and pitfalls. And again, don't forget the clinical context. These are places where I'm from, close to the Amalfi Coast and Naples. I hope you can go and visit because they are very beautiful. That said, thank you very much for your attention, and I will see you next time.